Hello, this is Dr. Naomi Fisher from Harvard Medical School and the Brigham and Women's Hospital, and I'm delighted to speak today about primary hypertension. I have no disclosures. We care about hypertension because the relationship of blood pressure to cardiovascular disease risk is continuous, it's consistent, and it's independent of other risk factors. We've learned a lot about high blood pressure and risk, including that cardiovascular risk doubles with every rise of 20/10, starting at a blood pressure of 115/75. These are from observational trials. For people over the age of 50, systolic blood pressure is a more important risk factor than diastolic blood pressure. These data come from the Framingham Heart Study. And in fact, we know that even if you're normotensive in midlife at the age of 55, there's a more than 90% chance that you will develop high blood pressure in your lifetime. Again, data from the Framingham Heart Study. And the reason for the incredible 90% prevalence is an increasing age in our population and increasing obesity. What are the benefits of lowering blood pressure? They are many. Here are three of the main ones, and you can see an average 50% reduction in heart failure, as well as a 35 to 40% reduction in stroke, and up to a 1/4% reduction in myocardial infarction. These data predict that a 12 millimeter reduction in systolic blood pressure over 10 years will prevent 1 death for every 11 patients treated, according to the JNC guidelines of stage 1 hypertension. Here are data from the National Health and Nutrition Examination Survey telling us how we have been doing as a country from the National Center for Health Statistics from 1999 to 2016. And you can see in the blue line here the prevalence of high blood pressure that it really hasn't changed. It's been pretty constant at about 30%. Of course, our definition hasn't changed in this time. So this was, 140/90, about 30% prevalence. And here's what happened with control of high blood pressure, and again, control here meant less than 140/90. And you can see that there was a great celebration as we hit a high of about 53% 9 or 10 years ago in the year 2010. And that's really been stagnant, and in fact, the most recent data from 2016 show a small drop of 48% control. So we have a lot of work to do. Here's the 54 that was celebratory, and here's the 48 indicating as a society that we're not even controlling half of our patients. And this again is with the old definition of high blood pressure, 140/90. So of course, we know that there were brand new guidelines put out by the American College of Cardiology and the American Heart Association, together with a cohort of several other professional organizations in 2017. And these really revolutionized how we think about high blood pressure. There are new blood pressure categories. This is a chart that you can find for your patients on the American Heart Association website, and it clearly defines what the categories are for blood pressure. So normal blood pressure is defined with a systolic blood pressure less than 120 and diastolic less than 80. If a systolic blood pressure now hovers in the 120s, the diagnosis is elevated blood pressure. High blood pressure stage 1 defines systolics in the 130 to 139 range, with diastolic blood pressure 80 to 89. Once blood pressure is 140 or higher, or 90 or higher, you're diagnosed with stage 2 hypertension. And you can see higher than 180/120 becomes a crisis or a hypertensive urgency. This chart compares the 2017 guidelines with JNC7, which was the last widely accepted guideline for hypertension in this country, the Joint National Committee of the National Heart, Lung, and Blood Institute. And it emphasizes that both JNC7 and the 2017 guidelines called normal blood pressure less than 120 and less than 80. JNC7 had a term which is now gone, called prehypertension, which defined both of these subsets. So of course, in the 120s, that's now been replaced by elevated blood pressure, and systolic in the 130s has been replaced by stage 1 hypertension. There's been an upgrade here between JNC7 and 2017. Stage 1 is now stage 2, and anything higher is still stage 2. So what happened? Of course, the prevalence of hypertension did not truly increase, but by our definition, the prevalence increased, and the increase appeared most in the young. You'll see in this display the percent of hypertensives in men up top and in women in the bottom, according to the new guidelines in blue, and the old guidelines in yellow, the old definition. So among young men in the 20 to 44 age bracket, the prevalence went from about 10 to 30, so it tripled and doubled in women. And of course, across the age spectrum, the prevalence rose in every age group. The new guidelines were driven largely by the Systolic Blood Pressure Intervention Trial, or SPRINT, which randomized 9,300 patients to a systolic blood pressure of 120 versus 140 millimolars of mercury. This trial was stopped early and published in 2015. The SPRINT trial enrolled patients who were over the age of 50 with systolic blood pressure between 130 and 180 millimeters of mercury, whether or not they were on treatment. And they had to have an additional cardiovascular disease risk factor, but not diabetes. And that could include cardiovascular disease, but not stroke, chronic kidney disease, or a Framingham risk score of greater than 15%, or simply age more than 75 years. And you can see here what the demographics looked like for these 9,000 plus patients. At the mean age was 68, and there was a good proportion of patients who were female and non-white. 91% were taking antihypertensive medications. The systolic blood pressure, while targeted for 140 and 120, reached 135 and 122 in the two arms of the treatment. Doctors were able to choose which medications they prescribed. In the beginning, both groups were taking about 2 medications for their blood pressure. And in the end of the trial, the standard treatment, they remained on 2 drugs, but the intensive treatment up to 3. So the big difference here was adding an antihypertensive medication. And the SPRINT trial demonstrated that the lower target translated to fewer events. Fewer events in the primary outcome, which was a composite of these, of 25%. And you can see the number needed to treat here, and also a reduction in death from any cause, so a markedly positive trial. It's important here, historically, to make mention of the report from the panel members appointed to the 8th Joint National Committee. So after JNC7, which was widely accepted, the NIH asked a panel to prepare the JNC8 report. The JNC8 panel report was published in 2014, but it was not endorsed by the NIH or the American Heart Association or any other body. It was published in JAMA. And its most controversial recommendation is that for patients over the age of 60, the target blood pressure should no longer be 140 over 90, but it should be 150 over 90. There was a strong dissenting minority that published its opinion in a separate journal in the same year and said half of the 80 million hypertensives in America are over the age of 60. And if we raise the goal from 140 to 150, this goal is going to apply to some of our patients at highest cardiovascular risk. There is insufficient evidence to support this increase, and it may reverse all of the progress we've made over the decades, especially in stroke mortality. So what have we learned since the panel report from JNC8 about treating high blood pressure more intensively in older people? This is an important study done by Williamson and published in 2016, looking at intensive versus standardized blood pressure control. So this was a subset of patients in SPRINT, a randomized trial only in patients who were at least 75 years old. And you can see the mean age of this group was actually 80. And comparing the standard treated to the intensive treated, the primary outcome was significantly reduced with hazard ratios of 0.66 and 0.7 for both primary outcome and all deaths. There were more adverse events among the intensive treated, but the adverse event rate among the older was not different from the overall cohort. So this teaches us now that we don't treat patients, certainly over the age of 60 or in their 70s, as old when it comes to controlling their high blood pressure. We'll talk now about evaluating your patients with high blood pressure. One of the important new recommendations is that we should now use out-of-office blood pressure measurements to confirm the diagnosis of hypertension and to titrate medication. in addition to using telehealth counseling or other clinical interventions. And this recommendation is class 1 with high level of evidence. We recognize now that the classification of blood pressure is in some ways conditional because blood pressure is different depending on where and how it's measured. So, for example, for stage 2 hypertension, we have a definition of an office blood pressure greater than 140/90. If you use an automated office blood pressure reading, like was used in the SPRINT trial, that will even be lower. So in the SPRINT trial, patients were left alone in a room for several minutes by themselves and taught how to push a button to take a blood pressure reading. Those numbers are more closely aligned with numbers that patients get when they measure their blood pressure at home, and stage 2 hypertension at home is defined by blood pressure greater than 135/85 with a home blood pressure monitor. Lower still are values for blood pressure that are obtained when patients undergo ambulatory blood pressure monitoring, such that an average 24-hour blood pressure greater than 140 or greater than 80 constitutes stage 2 hypertension. The measurement of home blood pressures may lead to alternate diagnosis. A normotensive patient will have no hypertension either in the office or at home, whereas someone with sustained hypertension is hypertensive both in the office and at home. But there are two classes called masked and white coat hypertension where there's a difference. So patients, I'll start with white coat hypertension. It's more familiar to most people, and that's where hypertension is isolated to the office or to the clinic, whereas at home there isn't any high blood pressure. It's normal blood pressure at home. Even hypertensive patients can have a higher blood pressure in the office, and we say they have a white coat effect on top of their hypertension. But white coat means that the blood pressure is elevated in the office compared to home. There is a converse condition called masked hypertension, where patients in the office have normal blood pressure, but at home or outside are hypertensive. Let's review some definitions. For decades, we used this term essential hypertension to describe what we now call primary hypertension. And this is hypertension for which the cause is unknown. We would otherwise perhaps call it idiopathic hypertension. And primary hypertension stands in distinction to secondary hypertension, where there's a known cause that is potentially correctable. And these include hormonal causes, some cardiac, renal causes, for example. And resistant hypertension, which describes high blood pressure which is uncontrolled despite the use of 3 antihypertensive medications in appropriate doses, one of which is a diuretic. Primary, or what we used to call essential hypertension, constitutes the vast majority of high blood pressure. Its etiology is very, very complex. We think about hypertension as a distant phenotype with interaction of multiple risk and protective genes and environmental contributors. Secondary hypertension includes chronic renal disease, renal vascular disease, primary aldosteronism, and some other endocrine causes like Cushing's syndrome and pheochromocytoma. And I put an asterisk next to aldosteronism because this is a cause that is underdiagnosed and very common, and something that you will pick up in your own clinic if you know to screen for it and do screen for it. We should understand many contributors to hypertension. It's a little bit of semantics. Some people would say that these are all causes for secondary hypertension, but they are contributors to high blood pressure. Obesity being very, very common, in fact, epidemic now, and aging, something that we can't do anything about, both of which contribute to high blood pressure. And then in green, I've listed here some contributors to high blood pressure, which are really contributors to maybe a pseudo-hypertension. So that's if we're not measuring the blood pressure appropriately, causing an improper measurement that's too high, or the white coat phenomenon, or non-adherence if a patient isn't taking his medication. And these other contributors include sleep apnea and chronic kidney disease. In the ALLHAT trial, a creatinine greater than 1.5 was the strongest predictor of resistant hypertension. Thyroid, parathyroid disease, excess sodium intake we'll talk about in a moment. And there are a number of drugs that can contribute, including, importantly, patients who take too much nonsteroidal anti-inflammatory drugs, glucocorticoids, cocaine, oral contraceptives in some women. Excess alcohol is a leading cause of reversible hypertension in this country. And then we have the endocrine causes of aldosteronism, renal artery stenosis, Cushing's disease, and pheochromocytoma, very rare. When do you rule out secondary causes of high blood pressure? And here are some general guidelines. You should think about secondary causes if hypertension has its onset before the age of 30. In patients who have resistant hypertension, again defined as blood pressure uncontrolled despite the use of 3 drugs in appropriate doses, including a diuretic. Patients who have abrupt hypertension or accelerated hypertension. Patients who present with signs or symptoms that would indicate a higher chance of having a secondary cause of hypertension, like pheochromocytoma, like renal artery stenosis, Cushing's disease, or hyperaldosteronism. The evaluation for secondary causes is beyond the scope of this talk, but I'd like to emphasize it's important to think about them all and to be a thorough clinician. You will not be able to diagnose renal vascular hypertension without having a strong clinical suspicion based largely on patient's demographic and comorbidities. Pheochromocytoma depends on taking a careful history. Cushing's syndrome, you will find clues on physical examination, and primary aldosteronism is a diagnosis that's only made by laboratory. Renal artery stenosis has undergone some changes in terms of its evaluation and therapy as a result of the CORAL study, the cardiovascular outcomes in renal atherosclerotic lesions, which was published in 2014. That was an open-label trial which randomized medical therapy against medical therapy plus stenting of the renal arteries in nearly 1,000 patients who had atherosclerotic renal artery stenosis and hypertension or chronic kidney disease or both. And the trial was, of course, negative. It showed no benefit of stenting for the composite primary endpoint or for any individual component. On the basis of this trial and former trials, we don't look so hard now for renal artery stenosis as a secondary cause unless we're going to be acting upon it therapeutically. And the treatment for renal artery stenosis, when do we stent? The expert recommendations are in cases of flash pulmonary edema, severe stenosis where medicine has failed, or acute coronary syndrome. Angioplasty is effective for the subtype of renal artery stenosis called FMD, fibromuscular dysplasia. So what is the treatment? It's intensive medical and lifestyle treatment, meaning an intensive statin. It's critical to stop smoking, to employ exercise, and to control hemoglobin A1C. It's important to think about primary aldosteronism because its prevalence is larger than we had previously thought, and because of the multitude of tissue effects that it brings, including left ventricular hypertrophy, coronary artery disease, atrial fibrillation, stroke, glucose intolerance, and kidney disease. These bullets help you know when to screen and when to suspect primary aldosteronism, and they come from guidelines published in 2016 by the Endocrine Society, who now recommends screening for primary aldosteronism in anyone who has a blood pressure greater than 150/100, patients who have hypokalemia that is either spontaneous or even diuretic induced, of course hypertension with an adrenal lesion, patients with resistant hypertension, patients who have a family history of early onset hypertension or early onset stroke, hypertensive first-degree relative of patients who have PA, primary aldosteronism, and hypertension and sleep apnea, which occurs with primary aldosteronism. The screen revolves around measuring simultaneous plasma aldosterone and a plasma renin activity while obtaining a plasma potassium to make sure that the K is not suppressed. It's important to get these measures before starting aldactone, or if you started aldactone, to withdraw this mineralocorticoid receptor antagonist at least 4 weeks prior to the ratio. The most commonly used cutoff is 30:1. Better than a ratio is to interpret both values, because if your plasma aldosterone is not greater than 10, look what happens. An aldo of 10 with a PRA of 0.1 will actually give you a ratio of 100. So with a fraction in the denominator, you can get a significantly increased value. If the plasma unit activity is suppressed with a patient on MR antagonist, you can interpret right through it. So now let's turn to the treatment of primary hypertension. And this is the key slide in the new guidelines dealing with treatment. We'll follow down the pathways here. For a patient with normal blood pressure, less than 120/80, it's appropriate to promote optimal lifestyle habits and have them come back in a year. For patients with elevated blood pressure, with a systolic blood pressure in the 120s and a diastolic less than 80, the treatment is non-pharmacologic. So this is lifestyle modification. It's very clear at the other end of the spectrum for stage 2 hypertension that you begin with lifestyle modification as well as medication, but here is what's new. Stage 1 hypertension 130 to 139 over 80 to 89. Just like with the lipid guidelines, the hypertension guidelines now include an estimation of the 10-year CVD risk. And if that risk is greater than 10%, that dictates you to add medications to lifestyle modification. So someone with a blood pressure of 132 over 80, 134 over 82, without high clinical CVD risk, it's appropriate for lifestyle modifications and to reassess in 3 to 6 months. But if the score is greater than 10%, then to proceed with blood pressure lowering medication and to reassess within a month. So more rapid titration of blood pressure medication. This chart shows you the relative reduction in systolic blood pressure that's obtained with different lifestyle modifications. And you can see that if you had to choose one, you would choose weight reduction and you would have your patients lose weight because that translates into the greatest reduction in systolic blood pressure. The dietary approaches to stop hypertension diet has proven to be very effective, and that's a diet rich in low-fat dairy and unprocessed grains and high in fruits and vegetables. Sodium reduction we'll speak about. Increasing physical activity, and the recommendation is 30 minutes at least 5 times a week, 150 minutes a week, and moderation of alcohol. Salt deserves a slide or two of its own because sodium consumption in excess is associated with death from heart disease. These are data from a large modeling study across 66 countries where the mean salt intake was 4 grams a day. And the majority of these data were taken from 24-hour urine sodium collections. And they demonstrate that 1 in 10 heart deaths are attributed to a sodium intake of more than 2 grams a day. And that this intake, in fact, is exceeded by almost the entire population of the world. The Food and Drug Administration recommends 2,300 milligrams of sodium, which is a level teaspoonful, in the course of a day, unless you have hypertension or are over the age of 50, or have diabetes, or are black, or have chronic kidney disease, in which case the recommendation for sodium intake is 1,500 milligrams in a day. It's really important to discuss this with patients because most Americans eat about triple the amount of sodium that they're supposed to for optimal cardiovascular health. So now let's talk about antihypertensive medications. First-line therapy, there's now a choice. There's an easy mnemonic, ABCD, where the A refers to ACE inhibitors and angiotensin receptor blockers, the B to beta blockers, the C to calcium channel blockers, and the D for diuretics. Notably, the B drug, the beta blockers, are no longer considered first-line therapy for the vast majority of patients with primary hypertension. And that's because beta blockers, compared to other therapies, showed an increased relative risk of stroke and increased diabetes in trials. It's not to say there isn't a place for beta blockade, because in patients who have heart failure with reduced ejection fraction and after myocardial infarction, they of course play a role. But for primary hypertension, we generally start with a choice of A, C, or D drug. First-line therapy then offers us a choice of an A drug, a C drug, or a D drug in most patients. We saw from the SPRINT data that most hypertensives will require at least 2 medications for blood pressure control, and if you have stage 2 hypertension or blood pressure more than 20 over 10 above goal, it's appropriate to start right away with 2 agents. To really maximize the chance of adherence, try to use combination therapy whenever you arrive at 2 fixed doses of a drug. Generic medications have been shown to really increase adherence, and once daily medications similarly. I want to talk about treating high blood pressure in particular patient subsets relevant to cardiology, and the first is stable ischemic heart disease. And the recommendations in this subset are a blood pressure target of less than 130/80, and that target is nearly universal for all patient subsets with the new guidelines. Patients who have stable ischemic heart disease and high blood pressure should be treated with medications, and that includes guideline-directed medical therapy beta blockers, of course, carvedilol, bisoprolol, metoprolol, succinate, and ACE inhibitors or angiotensin receptor blockers if they have a compelling indication, like a previous MI or stable angina, and that should be the first-line therapy. And then other drugs will be needed to further control hypertension. If there is angina in these patients and persistent uncontrolled hypertension, it's recommended to add a dihydropyridine calcium channel blocker. And the guidelines further say that if there's been an MI or acute coronary syndrome, it's reasonable to continue beta blocker therapy beyond 3 years as long-term therapy for hypertension. But it's also reasonable to think about calcium channel blockers to control hypertension who have coronary artery disease without HFrEF, who had an MI more than 3 years ago with angina. And let's talk about heart failure and the recommendations for treatment of hypertension in patients who have reduced ejection fraction. Again, you'll see the very familiar goal that these patients should be prescribed guideline-directed therapy to obtain blood pressure less than 130/80. Importantly, non-dihydropyridine calcium channel blockers are not recommended in the treatment of patients with reduced ejection fraction heart failure. How about patients who have preserved ejection fraction? These patients, especially with symptoms of volume overload, should begin their therapy with diuretics to control hypertension. After management of volume overload, ACE inhibitors or ARBs and beta blockers can be titrated, again, to achieve the systolic blood pressure goal of less than 130. On these slides, I won't talk through every point, but I'm going to leave them up to show you, and you can come back and refer to them, the benefits, the neutrality, and the downsides of the first 3 classes of drugs, A, C, and D classes of drugs. So here you can see some of the benefits of using an A-class drug and where they're neutral, and some of the risks that we have to think about. Similarly for calcium channel blockers and diuretics, and all the metabolic consequences of using thiazide diuretics. ISH here refers to isolated systolic hypertension. After those first 3 drugs, we have drugs classes 4 and 5 beta blockers and their particular recommendations and concerns, and mineralocorticoid receptor antagonists, and we have 2 approved in this country, spironolactone and eplerenone. Spironolactone and eplerenone, the mineralocorticoid receptor antagonists, are very effective for resistant hypertension. Here's the Pathway 2 trial by Brian Williams, which shows a crossover trial in 285 patients who had resistant hypertension. So they were hypertensive despite taking an A, a C, and a D drug. And they had a 2-week crossover trial, a 12-week crossover trial, where they were given either spironolactone, the alpha blocker doxazosin, or the beta blocker bisoprolol in addition. And you can see, compared with placebo, how much better spironolactone was as the 4th drug to add on. Just important to be careful about renal function and potassium when you're adding on an MR antagonist. Here are some of the 6th-line drug, you might call them, for treatment of truly resistant hypertension, which won't be used so frequently, but it's important to know about them. Of these, alpha blockers are probably used the most frequently. Before I conclude, having just talked about the different medications used to treat high blood pressure, it's time again to recognize renal denervation as a potential treatment, targeting the sympathetic nervous system. So renal denervation works on both the efferent and afferent limbs of the sympathetic nervous system responsible for salt and water retention, renin release, decreased renal blood flow, and increased central sympathetic tone. And as we all know, after a lot of hype and excitement from the Simplicity HTN-2 trial, the Simplicity HTN-3 trial was negative. This was a controlled trial in over 500 patients with resistant hypertension. It was blinded and randomized and controlled, and this means that every patient underwent renal angiography, had catheterization procedure performed. And in this trial, using a sham renal denervation as a control group, there was a failure to reach blood pressure endpoints, and it was a negative study published in the New England Journal in 2014. Some people thought this was the end of renal denervation as a potential therapy for hypertension. But there is an exciting new chapter, a next chapter that's currently being written. The study design of ongoing studies is significantly improved. Patient selection is very careful. There's better physician training and physician experience. All of these studies are blinded and controlled. There's improved technology, and they use either ultrasound or radio frequency for the ablation. There is effective circumferential renal nerve ablation in both renal arteries with the current studies. So renal denervation is showing promise. 3 trials were published in 2017 and 2018, including the Spiral HTN off-med trial in patients with mild to moderate hypertension, and the Radiance HTN solo trial using a different technology, using ultrasound in a set of patients that was nearly twice as large. And you can see ambulatory systolic blood pressure fell about 6 points more with denervation than with sham. And finally, the Spiral HTN on-med trial, looking at patients with resistant hypertension who continued taking medication through their procedure, and blood pressure fell about 7 points. So we're at very early stages, but very, very promising stages of renal denervation for the treatment of hypertension. When you treat patients with high blood pressure, of course, it goes without saying to treat all the other cardiovascular risk factors, including cigarette smoking, obesity, sedentary lifestyle, dyslipidemia, sleep apnea, and diabetes, to mention some of the most important. So in summary, I hope we've learned that there are many contributors to hypertension, both what we consider primary hypertension, with obesity, sodium, alcohol consumption, sleep apnea, and white coat contributing to the elevation of blood pressure, and secondary causes of hypertension, including renal parenchymal and vascular disease, primary aldosteronism, Cushing's, and Theo. And some of the summary points that I think are most important include the definition of hypertension now as a blood pressure greater than 130 or a blood pressure greater than 90 diastolic. We understand that lowering blood pressure reduces risk, so we now assess risk as well as assessing blood pressure, and there's a risk calculator in patients who have stage 1 hypertension in the new guidelines. We know that systolic blood pressure matters, especially in older patients. It's not considered a normal feature of aging to have a rising systolic blood pressure that we leave alone. There's an emphasis on accurate blood pressure measurement, including measurements taken out of the office to confirm the diagnosis of hypertension. A lot of the work now falls in the domain of the patient to make significant lifestyle changes to reduce their blood pressure. Adherence is such an important factor to think about, and we know we can increase it by employing daily medications, generic medications, and combination medications whenever possible. The goal blood pressure is less than 130 over 80 millimeters of mercury in most patients. And finally, one of the conclusions of the SPRINT data and sub-studies from SPRINT is that 60 is young. Let's address 2 post-talk questions. Here's the first question. Reducing blood pressure will reduce A, coronary artery disease more than any other target organ damage, B, stroke by about 10%, C, heart failure by about 50%, or D, all target organ damage to the same degree. Take a few seconds and give me your answer. The correct answer is heart failure by about 50%. Clinical trials have convincingly demonstrated a reduction in cardiovascular risk when we treat high blood pressure. We see reduction to the greatest degree in heart failure, about 50%, with significant reduction also seen in stroke, myocardial infarction, and progression of renal disease. Here's our second question. A 72-year-old man with type 2 diabetes and chronic renal insufficiency with a creatinine of 1.5 has a blood pressure of 140/90 on hydrochlorothiazide 25 milligrams and amlodipine 10 milligrams. What is the best treatment option? A, continue the current regimen. B, add lisinopril 10 milligrams. C, add atenolol 50 milligrams. Or D, double the hydrochlorothiazide to 50 milligrams. So there's one correct answer here. I'll let you choose it. The correct answer is B, add an ACE inhibitor. When hypertension is associated with diabetes, especially with chronic kidney disease, treatment should generally begin with an ACE inhibitor or with angiotensin receptor blockade. I'll leave you with some references, including, importantly, the new guidelines, as well as the SPRINT publication.